Today we will be discussing the evaluation and management of Vermian tumors. Briefly, we will explore strategies for the evaluation and management of Vermian tumors through an interesting case presentation. We will then explore relevant differential diagnoses, surgical approaches, and associated anatomy, and we'll conclude the presentation with a brief summary of the patient's postoperative course. A 64-year-old man with a history of emphysema and associated malignant pleural effusions presented to our facility with worsening imbalance and dizziness that had been progressive for approximately 6 months. He experienced multiple recurrent pleural effusions and was found to have a lung lesion that was highly concerning for malignancy. He underwent a thoracocentesis the year prior to presentation, but the fluid did not identify any evidence of malignancy. The patient was also then offered resection of the lung lesion, however, he elected to proceed with radiation instead. His social history was significant for tobacco use. On exam, the patient had no cranial nerve deficits, was awake, able to answer questions readily. His motor and sensory functioning was intact without any evidence of limb ataxia. Upon gait examination, he had severe imbalance and truncal ataxia. Imaging, and specifically MRI with and without contrast, revealed a sizable 3.5 centimeter enhancing tumor that was centered around the cerebellar vermis. The T1 post-gadolinium MRI axial, coronal, and sagittal images shown here demonstrate that the mass was effacing but not fully occluding the fourth ventricle. Supratentorially, there was no evidence of hydrocephalus, as shown in the last image, an axial T2 flare study. In this case, we must consider the most common differential diagnoses. One can group these based on their relation to the ventricular system, a strategy adapted from Ann Osborne's book titled Diagnostic Neuroradiology. In the adult, the most likely tumors surrounding the fourth ventricle are metastatic lesions. Hemangioblastoma, a highly vascular tumor often associated with a cyst, is also a possibility. In many of these cases, patients may have a positive family history for von Hippel-Lindau syndrome. In younger adults, medulloblastoma can present in this region and is usually found to originate in the roof of the fourth ventricle. These can be either solid or cystic. An ependymoma can also occur in this location and usually originates in the floor of the fourth ventricle and subsequently spreads through the foramina of Luschka and Magendie. This tumor is often likened to toothpaste spreading through these cerebrospinal fluid apertures. Other differential diagnoses include dermoid and epidermoid tumors, choroid plexus papillomas, which interestingly in adults are most commonly found in the fourth ventricle, whereas in children and neonates are typically found in the atrium of the lateral ventricles. Subependymoma and finally brainstem or cerebellar gliomas can also be found here, the lateral being exceptionally rare in this location. In the case of children, medulloblastoma, pilocytic astrocytoma, and ependymoma are the most common tumors in this region. Following the performance of a suboccipital craniotomy, there are two principal approaches that can be used to access Vermian lesions. The first is the T-lobular approach. This makes use of natural planes as the cerebellomedullary fissure and uvulotonsillar spaces are exposed. This approach is well suited for lesions of the foramina of Luschka, which can be reached laterally. A C1 laminectomy can be used to enhance rostral exposure by facilitating a greater inferior to superior working angle. A second approach that can be used to access Vermian lesions is the transvermian approach. This approach is typically used for large lesions that occupy the rostral fourth ventricle, and it is not well suited for lesions extending laterally into the lateral recesses. A portion of the vermis of the cerebellum must be divided to perform this approach, and patients undergoing this surgery are at risk for Vermian split syndrome, which can manifest with nystagmus, gait dysfunction, oscillation of the head and neck, truncal ataxia, disequilibrium, and cerebellar mutism. Cerebellar mutism is more likely to be seen in children, however, it can rarely present in adults as well. One must keep in mind the location of the nuclei of the cerebellum when performing either one of these approaches. In this diagram, the dorsal surface of the cerebellum has been removed, including its central vermis. The cerebellar nuclei are a group of 4 paired nuclei and include the emboliform, the dentate, the globose, and the fastigial nuclei. A classic mnemonic often used to remember these is "don't eat greasy foods," which corresponds to the cerebellar nuclei in lateral to medial order. We have created this helpful diagram to highlight the rich anatomy of the fourth ventricular floor. The fourth ventricular floor is rhomboid in shape. Its rostral 2/3 are located just posterior to the pons, while its caudal third is posterior to the medulla. The floor can also be thought of in relation to its cerebrospinal fluid inflow and outflow connections, which can be inferred in this diagram. At the rostral apex of the floor is the cerebral aqueduct. At its caudal tip is the obex, just anterior to the foramen of Magendie. The lateral angles of the floor lead to the lateral recesses and ultimately the foramina of Luschka and the cerebellopontine angles. The lateral recesses are horizontally connected by the stria medullaris. The floor of the fourth ventricle is vertically divided at its midline by the median sulcus, with each resultant half further divided by the sulcus limitans. The sulcus limitans separates the median eminence medially from the vestibular area laterally. The sulcus limitans deepens just lateral to the facial colliculus and the hypoglossal triangles to form dimples called the superior and inferior fovea. In the location of the superior fovea, the median eminence forms an elongated protrusion, the facial colliculus, which overlies the nucleus of the abducens nerve and an ascending portion of the facial nerve. The locus ceruleus is located at the rostral end of the sulcus limitans. The structure has a bluish hue due to the presence of pigmented neurons that contain neuromelanin. These are also responsible for a majority of norepinephrine production in the brain. More inferiorly, the hypoglossal triangle, vagal triangle, and area postrema can be found. Interestingly, this group of structures forms a shape reminiscent of the nib on an ink pen and are also referred to as the calamus scriptorius. The hypoglossal and vagal triangles overlie nuclei of the same name. The area postrema, when stimulated, can lead to nausea and vomiting. Patients undergoing surgery in this area may therefore experience a self-limited course of postoperative nausea and emesis, for which the use of antiemetic medications is especially efficacious. Not shown here is the auditory tubercle, which is a protrusion of the vestibular area and overlies the dorsal cochlear nucleus and the cochlear part of the vestibulocochlear nerve. Also not shown here is the posterior inferior cerebellar artery, which merges under the cerebellar tonsils. Given the rich functional anatomy of the floor of the fourth ventricle, care must be taken to avoid damage to these important structures, as excessive pressure or bipolar cautery, for example, may lead to postoperative deficits. In this case, we elected to use the transvermian approach as the tumor was found to be in the most rostral aspects of the fourth ventricle. It appeared to be extending to the vermian surface and did not extend to the lateral recesses. On postoperative imaging, a gross total resection was achieved as demonstrated in the MRI study shown here. In the first three images, corresponding to T1 postgadolinium coronal, sagittal, and axial sections, there was no evidence of nodular enhancement. There was some hyperintense signal within the resection cavity due to a small amount of residual blood products, as the cavity was lined with Surgicel to enhance hemostasis following surgery. The limited amount of postoperative blood products are confirmed when we compare the T1 postgadolinium axial image to a T1 pregadolinium image showing a hyperintense signal in the operative bed in both studies. The patient's ultimate pathology revealed the diagnosis of metastatic carcinoma with lung origin. Postoperatively, the patient was found to be at his baseline exam without any evidence of cranial nerve deficits, nystagmus, or any changes with his ataxia. His dizziness and imbalance gradually improved following his participation in a short rehabilitation program at an outpatient facility, after which the patient was able to be discharged home. He is currently doing well and is awaiting postoperative stereotactic radiation. In conclusion, the differential diagnosis for a Vermian mass in the adult patient includes metastasis, hemangioblastoma, and medulloblastoma. Both the telovelar and transvermian approaches may be employed to access tumors of the fourth ventricle. A strong understanding of the structures in the floor of the fourth ventricle is necessary for the safe resection of these tumors. These are helpful references used in the making of this presentation. Thank you for your time.